Unit 3, Classification and Assessment of Mental Disorders. NASH 3.1 Introduction. Broadly, assessment is concerned with the identification of distinguishing features of individual cases, whereas classification is concerned with the grouping of cases according to their distinguishing features. When people with emotional or mental problems seek your professional help, you need to have adequate knowledge of mental problems or disorders and a systematic approach to assessment. Taking a step-by-step approach to assessment helps to establish the problem and its impact on various aspects of the person's life and in decisions regarding the next steps in managing the problem. Objectives. After studying this unit, you will be able to differentiate between different classificatory systems for mental disorders, understand the various aspects of assessment, describe the process of carrying out assessment. 3.2 Classification of mental disorders. When you assess a client, you try to interpret her or his problems in terms of known disorders and assign a label, diagnosis, to the problems she or he is facing. These diagnoses are arranged according to groups of disorders within classificatory systems. 3.2 Classificatory systems. Knowing the classificatory system can help you in several ways. 1. Giving a client a diagnosis can help you decide on her or his management, as standardized management strategies are known for many diagnoses. 2. A diagnosis, which in essence is a summary of clinical information, can help you predict the course and outcome of the problems the individual is facing. 3. A diagnosis can help you communicate efficiently with other professionals who follow the same classificatory system regarding the client's problems. 4. Diagnoses and classificatory systems can help you group together and analyze individuals with similar sets of problems, thus aiding research. 3.2. The challenges of diagnosis and classification. Professionals know the exact cause of most medical conditions. However, a definite cause is not known for the majority of mental disorders. Thus, the diagnosis of mental disorders rests upon eliciting signs and symptoms in an individual and assigning a particular label, diagnosis, to these sets of signs and symptoms. In other medical illnesses, the physician can perform certain investigations to establish or refute the diagnosis reached on the basis of clinical signs and symptoms. For example, if a patient complains of a cough with sputum for more than 3 weeks, along with increased body temperature and loss of weight and appetite, the physician often makes a presumptive diagnosis of tuberculosis and then proceeds with investigations, chest x-ray, sputum examination, blood tests, etc. All these tests can help the physician confirm the diagnosis of tuberculosis, as there are few psychiatric diagnoses that can be definitively established by specific investigations. Psychiatric classifications are based on disorders defined by sets of signs and symptoms. 3.2.3 History of classificatory systems. For a long time, philosophers and researchers alike have tried to classify mental illness into various categories. Noted among them were Hippocrates, Aurelianus, Sydenham, Pinel, Kahlbaum, Greisinger, etc. Initially, mental illness was believed to be due to a disturbance of the humoral balance, or a disturbance in the tension of the solid tissues. However, later researchers such as Philippe Pinel linked the occurrence of mental illness to disordered functioning of the nervous system. Subsequently, many researchers unsuccessfully tried to link specific mental illnesses to specific lesions in the nervous system. Finally, Carl Ludwig Kahlbaum introduced the concept of diagnoses based on symptom complexes, sets of signs and symptoms, the distinction between organic, psychiatric disorders with known causes, and non-organic, psychiatric disorders without known causes disorders, and the consideration of age of onset as the basis of classificatory systems. In the last 2 decades of the 19th century, Kraepelin used 3 criteria: clinical description, course of the illness, and outcome of the illness, to distinguish between the major mental disorders. 3.24 Classificatory systems. The 2 most common classificatory systems, followed by professionals, are those advocated by the World Health Organization, WHO, and the American Psychiatric Association, APA. 1. International Classification of Diseases, ICD. This classificatory system is developed by the WHO to help researchers, clinicians, and health specialists code diseases and maintain statistical records of their hospitals. This system is updated every few years. The current version being followed is the 10th version of the ICD-10, which was published in 1992. There are a total of 21 chapters in ICD-10, of which the fifth chapter, Chapter 5, is dedicated to psychiatric illnesses. The version used by mental health professionals for clinical purposes is called the Clinical Description and Diagnostic Guidelines version. Other versions of the ICD-10, which are all mutually compatible, are depicted in the table below. SNO, ICD-10 version, description, purpose, Inc., Diagnostic Guidelines version. Other versions of the ICD compatible are depicted in the 10 version. 1. Clinical Description and Diagnostic Guidelines contains basic descriptions of each disorder, mainly for clinicians. 2. Diagnostic criteria for research. Each disorder contains specific criteria for diagnosis, mainly for researchers. 3. Primary Care version contains only 27 main categories with brief notes on management and referral, mainly for general physicians who work in the primary care setting. 4. Glossary contains meanings of various terms used in ICD-10. 5. Crosswalks, a comparison of ICD-10 categories with earlier versions of ICD. Mental and behavioral disorders in ICD-10 are given the code F. After the code F, the first digit of the diagnostic codes denotes the 10 major classes of mental and behavioral disorders as shown below. Codes. Categories. Categories. F0, F09, organic, including symptomatic mental disorders. F10, 19, mental and behavioral disorders due to psychoactive substance use. F20, F29, schizophrenia, schizotypal, and delusional disorders. F30, 39, mood affect disorders. F40, F49, neurotic, stress-related, and somatoform disorders. F50, 59, behavioral syndromes associated with physiological disturbances and physical factors. F60, F69, disorders of adult personality and behavior. F70, 79, mental retardation. F80, F89, disorders of psychological development. F90, F99, behavioral and emotional disorders with onset usually occurring in childhood and adolescence. After the first digit, the second and third digits denote further categorization of the disorder, while the fourth and fifth digits specify salient clinical characteristics of the diagnosis given by the 3-digit code. To provide an example, F32.11 denotes depressive episode, moderate, with somatic syndrome. This would mean F, mental and behavioral disorders. Mood, depressive disorders. Depressive episode. Moderate depressive episode. Presence of somatic syndrome. NAR2, Diagnostic and Statistical Manual, DSM. This classificatory system is developed by the American Psychiatric Association, APA. The fourth edition of DSM, DSM-4, was published in 1994. It has 17 sections as listed below. No section below. Delirium, other cognitive conditions. Disorders usually first diagnosed in infancy, childhood, or adolescence. 2. Delirium, dementionistic, or other cognitive disorders. Mental disorders due to general medical conditions. 4. Substance-related disorders. 5. Schizophrenia and other psychotic disorders. 6. Mood disorders. 7. Anxiety disorders. 8. Somatoform disorders. 9. Factitious disorders. 10. Dissociative disorders. 11. Sexual and gender identity disorders. 12. Eating disorders. Sleep disorders. 14. Impulse control disorders not elsewhere classified. Adjustment disorders. 16. Personality disorders. 17. Other conditions that may be a focus of clinical attention. Here, we will discuss ICD-10 in more detail in the next section. 3.2.5 Categories of mental disorders. Under ICD-10, as mentioned in the earlier section, mental illnesses are categorized into 10 distinct classes under ICD-10, Chapter 5. These classes are briefly described below. F9, organic, including symptomatic mental disorders. This category is for mental disorders that are causally related to brain damage or disordered functioning of the brain. The main disorders included under this cluster are dementias, delirium, amnestic syndromes, and psychiatric syndromes with well-established brain dysfunction, e.g., organic mood disorder. F10, F19, mental and behavioral disorders due to psychoactive substance use. Under this category, substances that can cause mental and behavioral disorders are first listed. This is followed by syndromes likely to be caused by these psychoactive substances. These include acute intoxication, harmful use, dependence syndrome, withdrawal syndrome, psychotic disorder, amnestic syndrome, residual and late onset psychosis. F29, schizophrenia, schizotypal, and delusional disorders. This cluster contains schizophrenia and its various subtypes, as well as other psychotic disorders such as schizotypal and delusional disorders, along with acute and transient psychosis. F30, F39, mood affective disorders. This cluster includes disorders that affect the mood of an individual, such as manic episode, bipolar affective disorder, depressive episode, recurrent depressive disorder, and persistent mood disorder, e.g. cyclothymia, dysthymia. F40, F49, neurotic, stress-related, and somatoform disorders. This cluster involves mental disorders previously termed as neuroses. These include obsessive-compulsive disorder, anxiety disorders, phobias, acute stress and post-traumatic stress disorder, dissociative and conversion disorders, somatoform disorders, as well as others such as neurasthenia and depersonalization derealization disorders. F50, F59, behavioral syndromes associated with physiological disturbances and physical factors. This cluster includes disorders associated with the disturbance of normal physiological mechanisms such as sleep, eating, and sex. Also included are disorders arising along with general medical conditions, as well as the abuse of non-dependence producing substances, antidepressants, analgesics, hormones. F60, F69, disorders of adult personality and behavior. There are two main clusters of disorders listed under this category. The first cluster relates to disordered functioning of one's personality. The second cluster relates to disorders of adult behavior not classified elsewhere. This includes impulse control disorders, disorders of gender identity, sexual preferences, and sexual orientation. The categories listed in ICD-10 after F69 involve disorders that start in childhood or adolescence. F70, F79, mental retardation. This category has only one disorder, mental retardation. It is a global disturbance in intellectual functioning that starts early in life. F80, F89, disorders of psychological development. This category includes disorders that affect specific aspects of intellectual functioning, such as language, speech, visual-spatial skills, and motor coordination. Another major class covered under this category consists of disorders characterized by deviation in the development of multiple intellectual abilities, called pervasive developmental disorders, e.g. autistic disorders, Rett syndrome, childhood disintegrative disorders. F90, F99, behavioral and emotional disorders with onset usually occurring in childhood and adolescence. In contrast to the two earlier categories, which affect intelligence or other aspects of brain development, this category covers disorders that affect the behavior and emotions of children and adolescents. This category includes hyperkinetic disorders, conduct disorders, anxiety disorders, tic disorders, and disorders related to physiological functioning such as enuresis, encopresis, feeding disorders, and pica. NASH 3.2.6, other aspects of classification. There are some categorical distinctions that were used officially in the past, but are still used routinely in clinical practice. 1. Organic versus functional illness. Organic illnesses are those that occur due to a demonstrable pathology of the brain or other body systems, e.g., delirium, dementia. Functional illnesses are, by default, those that have no such demonstrable pathology. While this classification appears simple, it has several fallacies. For example, it suggests, against established facts, that functional illnesses do not have biological causes, or that non-organic factors, such as psychological or social factors, are not important for organic illnesses. However, due to its utility and simplicity, this categorization is often used in clinical practice. TAC 2. Psychosis versus neurosis. The term psychosis is used to signify severe psychiatric disorders such as schizophrenia, bipolar disorder, and other disorders in which symptoms such as delusions and hallucinations predominate. In addition, Patients with psychotic disorders lack insight, that is, awareness that they have a mental disorder and are in need of treatment. The term neurosis, on the other hand, is used to denote disorders where anxiety is the predominant feature. Subjects with neurotic disorders typically present with insight into their illnesses, and the occurrence of their illness is often linked to psychological or social factors. With a greater understanding of psychiatric disorders, it is evident that most of the distinguishing features ascribed to either psychosis or neurosis do not fit all the disorders within these categories. For example, not all psychotic disorders are severe in nature, and not every case of neurosis involves insight. However, this distinction is simple to use and has thus survived in clinical practice, despite the fact that current classificatory systems tend to avoid the use of these terms. Multi-axial system of classification. Sometimes the patient's problems may span more than one domain. Both ICD-10 and DSM-4 provide provisions to record such information. The purpose of multi-axial classification is to promote a comprehensive biopsychosocial approach to clinical assessment. Multi-axial classification in ICD-10, Axis 1, clinical diagnosis, records all mental and non-mental conditions, including general medical conditions. Axis 2, disablements, records impairments in performance of basic social roles. Axis 3, contextual factors, records problems related to family support, housing, education, law, employment, family history, and personal life. Multi-axial classification in DSM-4, Axis 1, all clinical diagnoses except for personality disorders and mental retardation. Axis 2, personality disorders, mental retardation, and defense mechanisms. Axis 3, general medical conditions that may be relevant to understanding or managing the patient's psychiatric disorder. Axis 4, psychosocial and environmental problems relevant to the diagnosis, treatment, and prognosis of the patient's disorder. Axis 5, global assessment of functioning based on the clinician's judgment. 3.3, assessment of mental disorders. When a client comes to you, a detailed evaluation is necessary to understand their problems, label them correctly, and then help the client to overcome these problems. The detailed evaluation or assessment follows certain principles and is carried out systematically in a stepwise fashion. At times, the assessment cannot be carried out in a single sitting, and multiple sessions may be required to complete it. The extent of assessment also depends on the setting, outpatient, inpatient, etc. 3.3.1, why is assessment required? Assessment is required for the following purposes. 1. Establishing a diagnosis. An assessment should help you understand the nature of the client's problem and establish a working diagnosis based on which they can take steps to manage their problems. 2. Planning treatment. An assessment should help you plan the next steps in managing the problems, what needs to be done immediately and what needs to be done later. 3. Referral to a specialist for further management. The assessment should help you determine whether the client needs your help or the help of another specialist. 4. Establish rapport and make the client comfortable. An assessment can help you break the ice with the client and encourage them to voice their problems freely without fear of being misunderstood. 3.3.2, carrying out an assessment. The assessment is carried out in the following steps: eliciting history. 2. Mental status examination. 3. Physical examination. 4. Physical investigations. 5. Psychological assessment. 6. Assessment schedules and rating scales. 1. Eliciting history. Assessment begins with collecting the socio-demographic information of the client, such as age, gender, socioeconomic status, etc. In addition, details of the person accompanying the client should also be noted. You should then elicit information about the problems for which the client has sought your help. Initially, you should allow the client to explain their problems freely. After this largely spontaneous narration, you can seek clarifications to arrive at an understanding of the problems that can help you prioritize the course of action. The elicitation of history should cover the following areas: history of present problems or illness. Include any past history of similar problems or other psychological issues. History of medical illness. Include any history of substance use and family history of psychological or medical problems. Early developmental history. Include details such as the nature of birth, history of birth trauma, developmental milestones, and childhood psychological problems, e.g., temper tantrums, bedwetting, or conduct problems. Additionally, you should gather information about schooling. Note any related issues. Occupational history. Include job performance, frequent job changes, and job satisfaction. Marital history. Include years of marriage, divorce, and marital satisfaction. Sexual history. Include sexual preferences, early sexual encounters, current sexual functioning and satisfaction, and knowledge and attitudes towards sexual intercourse. Reproductive and menstrual history. In the case of female clients, include details about reproductive and menstrual health. Lastly, make an effort to understand the personality of the individual, which includes social interaction, predominant mood and any mood swings, character, attitude towards self, others, and work, predominant interests and hobbies pursued. This corrected version, ASH2, Mental Status Examination, MSE. You should carry out and record a detailed mental status examination, MSE. Conducting an MSE requires considerable skill, which can be learned by observing skilled interviewers and through practice under supervision. General appearance and behavior. The mental status examination begins as soon as the client enters the room, with observations of the client's general appearance and behavior. This includes build and nutritional status, gait and posture, manner of approaching and greeting the counselor, clothing, behavior towards the counselor and others in the room, client's movements, gestures, and facial expressions. In addition, the appropriateness of these aspects within the given sociocultural context should also be assessed. A. You should record both the client's description of their mood, your interpretation of their mood based on observations of facial expressions and gestures. Additionally, assess the appropriateness of the client's mood in relation to their situation and record it. Speech and thought. Speech. Observe and record the how of speech, including rate, quantity, and flow of speech, any difficulty or oddity in speech. Thought. Focus on the content of thought, including worries, obsessions, or delusions, ideas with specific themes such as suicidal or persecutory thoughts. Perception. Assess the client's interpretation of sensations, focusing on distortions, misinterpretation of normal sensations, e.g., mistaking a rope for a snake. Deceptions, reporting sensations that are not present, e.g., hallucinations such as hearing absent sounds. V. Cognitive functions. Cognitive functions are formally tested later in the MSE, but any gross disturbances observed during the interview should be addressed immediately. The assessment includes orientation. Evaluate the client's awareness of time, current date, day, time, season, and year. Place, home address and interview location. Person, identification of accompanying individuals. Attention and concentration. Assess informally during the interview or through formal tests such as digit span test, serial sevens, subtracting 7 serially from 100. Memory. Compare the client's responses with information provided by their attendant and during different points of the interview. Memory assessment involves 3 domains. Immediate memory. Ask the client to memorize 3 items and recall them after 1 and 5 minutes. Recent memory. Ask about events from the previous day, e.g., meals, mode of travel. Remote memory. Inquire about personal details, e.g., schooling, past residences, and general knowledge, e.g., names of past presidents. Note, if significant cognitive disturbances are found, refer the client to a medical center for further evaluation of medical or neurological conditions such as delirium or dementia. Judgment and insight. Judgment. Assess the client's personal judgment, their views about their future. Social judgment. Observed behavior with others during the interview. Test judgment. Provide a hypothetical scenario, e.g., what would you do if a house is on fire, and evaluate their response. Insight. Evaluate the client's understanding of their problems and possible solutions. Questions to address include, is the client aware that they are ill? Does the client think the illness is physical or mental? To what factors does the client attribute the illness? Does the client believe they need treatment? What kind of treatment does the client feel they need? 3. Physical examination. Physical examination is an important element of client assessment. If the counselor has not received medical training, they can refer the client to a general physician for a physical examination. Physical examination helps in the following ways. I. Some mental illnesses may have physical manifestations. For example, anxiety is often manifested by increased pulse rate, sweating, and tremors of the hands and legs. A proper physical examination will help the therapist assess these physical manifestations. T. Some mental symptoms may result from physical illnesses. Performing a physical examination will help establish the presence of such physical illnesses. For example, increased production of thyroid hormones results in anxiety symptoms, while decreased production of thyroid hormones results in depressive symptoms. T. Some medications for mental illnesses have significant side effects, and the client may need advice on their management. For example, a client experiencing weight gain while on a second-generation antipsychotic medication. Physical examination includes assessing general conditions such as pulse, blood pressure, temperature, and the presence or absence of anemia, jaundice, cyanosis, thyroid enlargement, etc. In addition, systemic examination of the cardiovascular, respiratory, abdominal, and neurological systems is required. 4. Physical investigations. Physical investigations are necessary to establish or rule out general medical conditions. Familiarity with basic investigations is useful for the counselor. Common investigations include hemogram, to assess hemoglobin levels, white cell count, etc. Liver and kidney function tests, often performed before starting psychotropic medications. Advanced investigations may include computerized tomography, CT of the brain, magnetic resonance imaging, MRI of the brain, and electroencephalogram, EEG, to assess brain electrical activity and rule out seizures or other disorders. #5. Psychological assessment. Sometimes, after the history and mental status examination, you may wish to obtain a more detailed assessment of the client's psychological functioning. Psychological assessments are performed by trained personnel, usually psychologists. The following domains are typically assessed using psychological tests. I. Neuropsychological assessment. This is usually performed when cognitive deficits are observed during the mental status examination. The assessment may focus on intelligence or other specific areas of cognitive functioning. Commonly used intelligence tests include Wechsler Adult Intelligence Scale, WAIS, Wechsler Intelligence Scale for Children, WIS, Stanford Binet Test, or its adaptations for children. Commonly used cognitive function tests include Luria Nebraska Neuropsychological Battery, Halstead-Wrighton Neuropsychological Battery. Standardized Indian adaptations are available for many neuropsychological tests and batteries. I. Personality tests. Some commonly used personality tests are Minnesota Multiphasic Personality Inventory, MMPI, Eysenck Personality Questionnaire, EPQ, Multiphasic Questionnaire. Indian adaptations of these tests are also available. Projective tests. These tests use ambiguous stimuli to elicit responses from the individual. The responses are analyzed to understand the individual's thinking patterns, personality traits, and unconscious thoughts or feelings. Commonly used projective tests include Rorschach Inkblot Test, Thematic Apperception Test, TAT, Sentence Completion Test, NASH-6, Assessment Schedules and Rating Scales. A number of interview schedules have been devised to make clinical assessments more uniform. Specific training is required to use them properly. Some well-known assessment schedules that help with the diagnosis of mental disorders are Schedule for Clinical Assessment in Neuropsychiatry TRAN, Present Status Examination, PSE, Composite International Diagnostic Interview, CIDI, Diagnostic Interview Schedule, D, Structured Clinical Interview for DSM-4, Schedule for Affective Disorders and Schizophrenia, SAS. In addition, there are several tools that can rate the severity of a disorder that the client is suffering from. These scales help in tracking the progress of the illness or recovery. Examples include I. Schizophrenia, Scale for Assessment of Positive Symptoms, SAPS, Scale for Assessment of Negative Symptoms, SANS, Positive and Negative Symptom Scale, PANS, Brief Psychiatric Rating Scale, BPRS, Mania, Young Mania Rating Scale, YMRS, Manic State Rating Scale, MSRS. Depression, Hamilton Depression Rating Scale, Zung Depression Scale, ZDS. Montgomery-Asberg Depression Rating Scale, MARS. Beck Depression Inventory, BDI. Anxiety, Hamilton Anxiety Rating Scale, HARS. Yale Brown Obsessive Compulsive Scale, YBO. V. General Health Quality of Life, General Health Questionnaire, GHQ. World Health Organization Quality of Life Scale, WHO QOL. Global Assessment of Functioning, AF. Some of these tools are used by counselors and family therapists, while others are used by psychiatrists or psychologists. DAS 3.4, let us sum up. In this unit, we have covered two aspects, classification and assessment. In classification, we have learned the basic concept of classification, including the various purposes of classification, the different classificatory systems used, as well as a description of various classes under the ICD-10 classificatory system. In the assessment section, the benefits of assessment were covered, along with the various forms of assessment. 3.5. Acute and transient psychosis, a disorder in which psychotic symptoms, such as delusions, hallucinations, or bizarre behavior, appear suddenly and last only for a total duration of hours to weeks. Adjustment disorder, a disorder in which subjective distress and emotional disturbance arise during adaptation to a significant life event. The symptoms appear within 1 month and resolve within 6 months of the life event. Amnestic disorders, disorders characterized by the loss of memory. Anxiety, the apprehensive anticipation of future danger or misfortune, accompanied by somatic symptoms of tension. Conversion disorder, a disorder in which intrapsychic conflicts that would otherwise give rise to anxiety are instead given symbolic external expression in the form of symptoms that mimic neurological symptoms. Delirium, an acute, usually temporary condition characterized by disorientation and difficulty with attention and memory. It may be accompanied by hallucinations, anxiety, incoherent speech, restlessness, and delusions. It is caused by medical surgical conditions such as high fever, trauma, or alcohol withdrawal, delirium tremens. It is an emergency requiring prompt treatment. Delusion, a false belief based on incorrect inference about external reality that is held firmly despite obvious evidence to the contrary. Such beliefs are not ordinarily accepted by other members of the person's culture or subculture. Delusional disorders, disorders in which delusion is the prominent symptom. Dementia, a progressive decline in cognitive function beyond what might be expected from normal aging. Depersonalization, an alteration in the perception or experience of the self so that one feels detached from and as if observing one's own mental processes or body from the outside. Derealization, an alteration in the perception or experience of the external world so that it seems strange or unreal, e.g., people may appear two-dimensional or mechanical. Dissociative disorders, disorders in which there is a disruption in the usually integrated functions of consciousness, memory, identity, or perception of the environment. Encopresis, the passage of stool in inappropriate places by individuals who are expected to be continent or have already been toilet trained. Enuresis, involuntary urination after the age at which bladder control would normally be anticipated. Factitious disorders, psychiatric conditions in which an individual presents with an illness that is deliberately produced for the sole purpose of assuming a sick role. Gender identity disorders, disorders in which a person's inner conviction of being male or female is disturbed. Impulse control disorders, a set of psychiatric disorders characterized by a compelling desire to perform a particular task or activity. This includes intermittent explosive disorder, kleptomania, stealing, pathological gambling, pyromania, fire starting, and trichotillomania, hair pulling. Mental retardation, a disorder characterized by sub-average cognitive functioning. Mood affective disorders, disorders in which the major problem is mood regulation. The mood may be too low, depression, too high, mania, or alternate between high and low, bipolar disorder. Obsession, a recurrent and persistent thought, impulse, or image experienced as intrusive and distressing. It is recognized as being excessive and unreasonable, even though it originates in one's own mind. This thought, impulse, or image cannot be dismissed by logic or reasoning. Repetitive, ritualistic behavior, such as hand washing or ordering that aims to prevent or reduce distress or avert some dreaded event or situation. The person feels compelled to perform such actions in response to an obsession or according to rigidly applied rules, even though the behaviors are recognized as excessive or unreasonable. Obsessive compulsive disorders, disorders characterized by obsessions and compulsions. Personality disorders, disorders characterized by rigid and ongoing patterns of feeling, thinking, and behavior. The inflexibility and pervasiveness of these behavioral patterns often cause serious personal and social difficulties, as well as functional impairments. Phobia, a persistent, irrational fear of a specific object, activity, or situation, leading to avoidance of the feared stimulus. For example, agoraphobia refers to the fear of open spaces or crowded public places, which results in a fear of leaving a safe place. A disorder characterized by the desire to consume or eat non-nutritive substances, e.g. chalk, soil, paper, mucus, or ash. Psychoactive substance, a chemical that acts primarily upon the central nervous system, resulting in temporary changes in mood, behavior, consciousness, and perception. These substances are often used recreationally to purposefully alter one's state of mind. Schizophrenia, a persistent psychotic illness characterized by symptoms such as hallucinations, e.g., hearing things spoken about oneself in the third person, delusions, e.g., believing one's thoughts are known to others without consent, and feelings of being controlled by external forces. Schizotypal disorder, a disorder characterized by social isolation, odd behavior and thinking, and unconventional beliefs. Somatoform disorder, a disorder characterized by physical symptoms that mimic disease or injury for which there is no identifiable physical cause. These symptoms are believed to be related to psychological factors.